Yes, good morning once again, distinguished participants, some members of the Association of Lagos State Retired Heads of Service and Permanent Secretary that are on the call, retirees, and seven officers. I welcome you all to today's webinar session on pneumonia. Yeah, my name is Bisi Roland, sorry, from Post Service Department, Office of the Head of Service. And I'd like to call on our Director of Post Service Department, Mrs. Durodola Olushola Bukola, to please declare the session open. Ma, can you please unmute yourself? Hello, ma. Hello, ma. Okay.
Yeah. Good morning, distinguished participants on this call. I want to specially recognize all the retired permanent secretaries on this call. It's a pleasure to welcome you to this call this morning. I have just a very simple assignment to declare this webinar open on behalf of the head of service and the permanent secretary, who are both unavoidably absent this morning. Like we have been told, our topic this morning is pneumonia. As we all know, good health is one of our greatest assets, especially in old age. Today's session is aimed at helping us to detect, to prevent, and to manage this health condition. I will advise that we get a pen, get a jotter so that we can make notes. Let us also ensure that we go back to the YouTube channel to listen over and over again so that we can internalize and ensure that we keep in good health. From our end here in the Lagos State Public Service, your health is very paramount to us. We want to see you enjoy good health in retirement. So on that note, I would like to declare this webinar session open, and I hereby hand over to Mrs. Roland to introduce our facilitator for today. Thank you very much and welcome to this call.
Yeah, thank you, ma'am. Just to add to what our director said, you are free to ask questions during the question and answer session by raising your hand or dropping your questions in the chat box. Yes. So our facilitator for today is Dr. Odumuye Demilade. She's a medical doctor who is passionate about health, beauty, and wellness. She's a medical graduate from Olabisi Onabanjo University with work experience spanning through the public and private sector, including Reddington Multi-Specialist Hospital, Bagada and Alimosho General Hospitals. She presently works at Lagos State Primary Health Care Board, and she embraces holistic health, including mental health. Her professional priorities focus on disease prevention and health education to help individuals lead better lives. Her hobbies include reading and singing. Good morning, doctor. Please, can you unmute yourself? All
Good
right. Good
morning,
morning.
Ma. morning,
Thank you
everyone.
for being here. You're welcome.
Thank you for the opportunity to speak with us here today. Thank you.
You're welcome. Please go ahead.
So, can I go ahead?
Yes, you can.
Okay. Good morning, everyone. Good morning, Daddy. Because obviously you're all older than I am. Retirees, thank you so much for the opportunity to speak with us this morning. I'm going to be speaking on the topic pneumonia as it affects our lungs, basically, because this disease is more common than we know about it, and certain signs are masked under certain other conditions like the common flu. Please, am I audible enough?
Yes, we can hear you.
I'd I'd like to know at every point that they can hear me.
All right.
In case anyone is finding it difficult to hear me as I progress, please drop the note in the comments or the chat box so I can know and then reiterate. Thank
All
you.
right.
So the slide that we have, am I able to maneuver this? Okay, fine. So this picture is just showing that we know where the lungs are. They're in the chest cavity. So the picture is basically focusing on what happens in pneumonia. So our lungs are the organs of respiration, meaning that they are the organs we use to breathe. Breathing in oxygen, breathing out carbon dioxide. These are the two major gases that we need for respiration to occur. And that is like with other processes showing that one is alive, basically. So the lungs have different parts, or should I say the respiratory system has different parts that come to play in this gaseous exchange, starting from our nostrils, to the trachea, that's the windpipe, even to the bronchioles that divide, into the lungs, the two lungs. So this picture that highlights normal and pneumonia is showing the functional units. That's the smallest or tiniest unit in the respiratory system. It is showing us how in the normal picture, we can see that there's nothing colored in it, basically, meaning that air, air is supposed to be colorless, light, there's no fluid attached to it. So meaning that gaseous exchange happens here, and then the sacs fill up like you blow into a balloon and then it goes back. That is why we have a chest rising and falling when we breathe. However, in the case of pneumonia, something happens to this breathing unit such that so many several, or how would I put it, several disease conditions or several pathogens or things that can cause a disease of this functional unit will lead to ultimately having the gaseous exchange reduced as a result of fluids coming into that system. They are not supposed to be there on a normal day. But this fluid filled with some other cells as we progress and see what contains in the exudate, and then some other things like pus in some cases would actually fill up those otherwise, air-like sacs, causing difficulty in breathing because, of course, fluid has already entered into it. So the gaseous exchange is difficult. Expansion of how something like a balloon or a breathing unit should look like is. So as we progress, we'll get to know. But it's just good to put as a matter of introduction that from your nostrils, there are several mechanisms or things that are put in place, structural and functional, that help you breathe in such that when you get to this lowest part of the lungs, you are not supposed to have things like microorganisms, fluids, or what have you in this system. It's just supposed to be air, basically. Oxygen comes in, oxygenated air, and then carbon dioxide goes out into the blood to be recycled again through the red blood cells. So from the nose, because I'll still repeat it, but I just want us to have a background. We have our nose hairs. If everybody has looked into their nose at one point, or if we have like older people, or if you're looking at somebody else talking, we have certain types of nose hairs. It doesn't have to be prominent hairs like our hair on our heads, right? But these hairs play a role in trying to like filter the air that is coming in, because the air that is coming in can be filled with dust, can be filled with spores or what have you. So that's one protective mechanism such that organisms don't get to the lower part of the lungs where these alveoli or air sacs are. When you go on through the trachea, that's around the throat area, you have certain cells that produce mucus to try to like trap things and keep them higher up. And then when you're going further down, there are other mechanisms that help us, such that when you get to this level, you don't have organisms that can elicit a response or an inflammation that leads to pneumonia. So pneumonia very quickly is an acute infection of the parenchyma of the lung. That's like this fraction, smaller unit, right? In which there's consolidation of affected parts and a filling of the alveoli air spaces with exudate, fibrin, and inflammatory cells. I said earlier that there are several other things that will be there. Fluid, that's like the exudate is protein rich because there's a reaction with several cells in our bodies forming certain things, and inflammatory cells. So when you go further down, the protective system is if things have escaped your nose hairs and the mucus and cilia, like there's something like a conduction belt around the upper respiratory area whereby mucus traps it, and then these things like hair-like projections try to push it up, such that you have other things like a cough reflex that helps you cough when something gets in, to forcefully bring out these things back so that that parenchymal unit is kept sterile or free from microorganisms that can cause infections. So if we have these inflammatory cells, that's like the further stage of protection, such that, okay, there are some cells that act like a defense mechanism. There are different cells anyway interplaying. They're called white blood cells. We know that white blood cells help us defend our bodies. So these particular white blood cells are like macrophages. They try to like swallow up things. So these things have escaped your nose hairs, they have escaped the other mechanisms that are involved. Now it is in a critical unit where we need only air. We don't need particles. We don't need any other thing. So they try to like swallow it up to cover it so that it doesn't spread or cause further problems. So those are the inflammatory cells. So there's a term, if we go into the next slide, we'll see a picture. There's a term called pneumonitis. When you hear itis, it's more like, inflammation. Itis talks about inflammation, swelling, right? So pneumonitis, because, the air is, the chest, the lungs rather, is the breathing unit. So pneumonitis is a term that we use for inflammation of, the lung parenchyma or the lungs as a unit, when it is caused by physical processes, allergies. For some people, maybe during rainy season, you sneeze more. That's a form of allergy. Or some chemicals. There are sometimes we inhale some toxins or some certain harmful substances that they also elicit this pneumonia-like reaction. So pneumonitis is a term that we use for this inflammatory process, whatever causes it, whether physical, chemical, allergic. Meanwhile, pneumonia is a form of pneumonitis. So it's like under this umbrella. So whatever causes the inflammation of the lungs, the general term for lung inflammation, whether it's medicines, radiation, stomach acid if you vomit or regurgitate, or if you have this reflux disease that some people might call heartburn. So peradventure it gets into your lungs by mistake. These things that cause a swelling or an inflammatory process is called pneumonitis. But pneumonia is a form of pneumonitis that can be caused by bacteria, fungi in rare cases, viruses, aspiration like I mentioned. So it is considered a type of pneumonitis. Okay, so we can move on. So the epidemiology is good to understand when we say a disease is important, especially in the community. You want to know how it affects certain people. That's what the epidemiology is talking about. There are several data we find in India, we find in the US, as you would see in the slides. But the data for Nigeria, well, I was not able to get my hands on like definitive data, though people do research, don't get me wrong. So here, the epidemiology I'm using is for the US. It's one of the leading causes of morbidity and mortality in the US. And then it affects ages that are under 5, that's the children, and the ages over the age of 65 years. That is why it's relevant in this presentation, because I believe that our age group spans around 60 upwards. And then annually in the US, they have recorded more than 3 million cases in which, sometimes it happens in the cold weather, in their winter, whereby there's upper and respiratory tract infection that might weaken the immune system. And when our immune system, all these protective cells that swing into action to take care of whatever bacteria or microorganism that enters into our lungs, as well as the whole body as a function, when they are weakened, certain things can seep in, certain things can come in that should not ordinarily enter. That's what I mean by bacterial superinfection. Most times in the winter, it's usually viral for them because those are the types of things like flu-like symptoms, influenza, and what have you that we have, such that it elicits this cold, what they call flu, runny nose, sometimes fever, cough, which might be dry, headaches, congestion, what have you. So that's the epidemiology. So even bringing it down to Nigeria, it really occurs commonly. In this rainy season, we might think, oh, it's just cough. Oh, it's just a respiratory tract infection. But you never know. It could be pneumonia. That's why we're going to be looking at how it happens, what are the things we can do, what are the signs we can see, and how can we know when to present to the hospital. So the pathophysiology, moving on to the next slide. The pathophysiology is, I've shown a picture earlier on of the alveoli. Those are those like air sacs, those sacs that look like an outpouching. They are the basic functional units of the lung that are responsible for gaseous exchange between the atmosphere, air, and red blood cells. So the red blood cells have a role to play in oxygenation because they carry oxygen. So red blood cells flow along these alveoli parts. They are capillaries, more like tinier systems or networks, coming from the arteries or the veins down to the finer networks that are able to coat these thin basic functional units of the lungs, such that the red blood cells are responsible. When carbon dioxide is produced and oxygen goes in, they take the carbon dioxide, goes back through the heart to the lungs to oxygenate, and that's the continuous process of breathing. How many of us have noticed that we don't stop breathing until there's a problem or the person is about to cross to the other side? So the breathing is a continuous thing, just the same way your heart also functions. You don't really know if your heart takes a break. It just keeps pumping per minute. So there are protective mechanisms like physical and humoral barriers that help prevent foreign particles from getting into the basic units. I've tried to explain that earlier. Physical barriers like your nostrils, hair, mucociliary blankets. These are the things I told you produces mucus, and then something like some projections like a hair-like thing that helps to move up mucus and these particles that are trapped in it. Sneezing and coughing reflex alongside some humoral barriers. So those are like the further down the general defense mechanism of the body. The humoral barriers like the macrophages and certain substances produced lower down in the lungs called defensins that all play a role in helping us, keep these functional units going. Next slide, please. So when the immune system is weak or particles cannot be swallowed by the macrophages, these things that swallow up or engulf foreign particles, they can cause damage to the lung endothelium. That's like the lining of the lungs, the functional unit of the lungs, which lead to these macrophages. Certain things ought not to seep out. If you understand disease process, say we know that we have common bacteria that occur on our skin, even along the upper respiratory airway, the upper respiratory tract, and certain other organs. But when something breaks the barrier, when something, maybe it defense weaken the immune system, a cut or trauma that breaks the barrier, when that happens, then these things that are naturally occurring that are not supposed to cause harm can now cause a disease process. So when the alveolar macrophages are released, they release interleukins and cytokines. These are like further chemicals down there, and neutrophils, part of the white blood cells component, and monocytes. All these things swing into action. We want to try to control the situation so it doesn't become a systemic thing. Because remember, I said the capillaries, the thinnest, finest, like something like a pipe that supplies blood cells to this thin network of the breathing unit, would actually carry particles like the air going in and out. So the same way, if these things are broken down, if this integrity of the endothelium is broken down and things can cross, then certain disease-causing particles or organisms can enter into the blood system because it goes back and forth, back and forth. It's a continuous process. So when this happens, it can spread this infection to other parts. So walling off of the particles is more like keeping it in a sack, prevents or stops the infection from spreading. And then these neutrophils that enter in the white blood cells, mixed with the bacteria and what have you, now form pus, debris, meaning fluid, thickened things as a result of the reaction with some of the bacteria, and then it makes gaseous exchange difficult. That is why there's difficulty in breathing, because the system that ought to just accommodate air alone is now being filled with fluid. Next slide. So it also shows like a cross section of the alveoli, such that you see from the pulmonary artery, the endothelial cells encapsulate. The red showing that CO2 goes out, and then air comes in, oxygen oxygenating, the blood that goes back to the pulmonary vein, the capillary vein, the red blood cells lining, basically. Okay, so the next slide. So we have several classifications of pneumonia. There are several classifications of pneumonia. You can say, oh, that the pneumonia is classified based on the things that cause it, the pathogen, the causative agent. Pneumonia can be classified based on anatomy, meaning where you find these disease conditions happening along, the lung zones. It can also be classified by how you acquire it. Where did you get the pneumonia? Is it in your community? Maybe certain flu is going around. The next slide, please. Maybe certain flu is going around, or is it as a result of certain respiratory illnesses? Some people have asthma, some people have pre-existing conditions, some people have the chronic obstructive pulmonary disease that makes breathing difficult, and certain other things can now come and cause problems. So we'll be looking at these classifications very quickly. So pneumonia classification by pathogens, divides the pneumonia into causative organisms. Are they viruses? Are they fungi? Is it a bacteria that is causing it? And there are several types of these organisms. So I picked listing them according to the most common that we see in our environment. So pneumonia by pathogens are classified as bacteria, viral, and fungal, like I said. The bacteria is the most common cause of pneumonia, basically. And certain bacteria that commonly cause pneumonia are like Streptococcus pneumoniae, which is like the chiefest of the chief, if you permit me to use that expression. These are like organisms that are the number one cause commonly in the environment. They are the core pathogen. Then other bacteria like Haemophilus influenza can cause it. Mycoplasma pneumoniae, Klebsiella. I'm on the next slide. Staphylococcus, which should ordinarily be on your skin. But when there's like a breach in this defense process, it can get into the airway and cause serious illnesses. Legionella, pneumophilia, chlamydia, Moraxella catarrhalis, and so many other bacteria. But these are the ones that we commonly culture. Now, viruses like influenza, parainfluenza viruses can cause the viral pneumonia. Respiratory syncytial virus can cause it. Cytomegalovirus can also cause pneumonia, alongside the other variants like the COVID virus, the rhinovirus, the adenoviruses. So, the fungal causes are rare, but they occur in people that have their immune system compromised, the immunocompromised patients, either as a result of an infectious process, be it HIV infection or the progressive disease AIDS, or people who have had to have certain medications called steroids that suppress certain things. So if people have organ transplants, they are giving steroids. A long use of the steroids can weaken the immune system. But they need the steroids also so that whatever organ they've received from someone else can carry them for a number of years. So, chronic illnesses that are not controlled, like diabetes mellitus, can also weaken the immune system, encourage bacterial growth rapidly, and ultimately cause a fungal part. These fungals might just be occurring normally, but then when they get into the airway, they cause a disease progression, which elicits pneumonia. So classification by anatomy, how the lung is formed. I would like us to quickly go to the picture. Oh, okay. I didn't mention that Candida examples of the fungi, sorry, Candida, Aspergillosis, Pneumocystis jirovecii. They are like types of fungi that can elicit pneumonia. Different things affect different organs more commonly than others. So these ones are more common. So based on the anatomy of the lung, if we can see this picture, it starts with the windpipe, the trachea. We have cut off the nostrils and the nose hair. We are looking at the respiratory system proper. So on the right, the lungs have three lobes actually. The upper lobe, the middle lobe, and the lower lobes or lung lobes. That's the right lobe. Meanwhile, on the left, we have two lobes. That is the upper lobe and the lower lobe. So there are several things from the trachea that branches out, more like a tree. So the trachea is the one windpipe, and then you have the two main bronchus or the bronchi, left and right, that enters into the lungs. Then the bronchi now breaks down into further things, bronchioles, all the way down to the alveolar sac that we saw in the picture earlier. So based on the area of the lung affected, we can now name the type of pneumonia. So we have lobar pneumonia affecting a whole lung lobe. It could be the upper, middle, lower. It could be all of the three lobes on the right. It could affect one lobe on the left, one lobe on the right. It could affect two lobes on the left. It could be one or more lobes affected, of which there is uniform inflammation and consolidation. So I don't know if I put it in the presentation, but I wrote out that consolidation is like a pathological process whereby the alveolar is filled with a mixture of inflammatory exudate, whether bacteria, white blood cells, and then they appear opaque on chest x-ray. So you can't talk about consolidation until you do a chest x-ray. Although several other signs can give you an idea that, oh, something is going on in this particular lung lobe. Several respiratory examination that can give you this idea. So when it affects a lobe such that a whole lobe, entire lobe at that point is filled with something like fluid that you can see on x-ray that appears opaque or different from the rest of the lung zones, maybe lighter. It usually appears whiter than others. You can call it a lobar pneumonia. You can now say, oh, it's a right lobar pneumonia, right middle lobar, what have you qualifying it. But when it affects the bronchioles or the bronchi, you have bronchopneumonia or bronchial pneumonia, as the case might be. It's a typical pneumonia that affects, patches throughout the lungs. So these are talking about radiology, what you see on X-ray, basically. So it appears like patches, white dots all around. But the difference between this one and the lobar pneumonia is that for the lobes, you see that a particular place, uniform, appears whitish. But for these ones, there are areas of darker, areas on the lungs showing that, oh, normal gaseous exchange is happening. However, some patches like seed, or something like that spans throughout, the airway passages, the bronchial, to the nearby sacs. So as they are dividing, it might pick like a particular branch of a tree. Permit me to use that analogy. And that's just the area that is affected. Then we have interstitial pneumonia, which is an atypical pneumonia in which inflammation occurs in the tissue between the air sacs. That's the interstitium. So that is what the classification by anatomy slide is trying to explain. But I wanted us to have like a visual to see how it goes. That we have three lobes on the right and two lobes on the left. Moving on to mode of acquiring pneumonia. We have the ones that are acquired in the community acquired pneumonia, and we also have the ones acquired in the hospital. So everybody knows that the hospital is well, I'll say that a place whereby you can have different organisms. Permit me to use that word. Different things can occur in the hospital because different people come with different things and we all meet together, right? So when you have community acquired pneumonia, you know where you got it. It wasn't gotten in a extended care facility or, an immunocompromised patient, so to say. So it was gotten as a result of being outside the hospital, whether in your community, your neighbor's house, on your street, or what have you. And, it's not also gotten by people that are immunocompromised because that can also be another classification. However, hospital-acquired or nosocomial pneumonia is pneumonia that is acquired in the hospital setting within 2 or more days after hospital admission or less than 7 days after the patient has been discharged. So you can have an idea that, oh, this person spent some time in the hospital, though it's not a week yet that the patient was discharged. So we can trace that disease condition or the symptoms we're having back to, oh, maybe the person went for malaria treatment and had to be admitted, and the person is coming back with cough and so many other presenting signs or symptoms of pneumonia. You can trace it back that, oh, the person got this while the person was in the hospital. And then under the hospital pneumonia, you can have ventilator-acquired pneumonia. That's for people that are on life support. That's in the ICU, the intensive care unit. So they're attached to a ventilator. And because maybe due to staff care or the tubings being laced with microorganisms, and because they are intubated, because they are sedated or put in coma to help their organs recover, they don't have that cough reflex that will help them push out when something goes in. So they are also susceptible to ventilator-acquired pneumonia. Slide 15, classification by pre-existing respiratory system. So it depends. Yes, it depends on, if the person previously had some form of illnesses that affects the lungs or not. So a primary pneumonia is pneumonia that occurs in an individual of which there is no pre-existing or abnormality of the respiratory system. There's no asthma that is worsened. There's no COPD, that's the chronic obstructive pulmonary disease. So this pneumonia just occurs on its own. This is the first time. Can you hear me, please?
Yes, we are
We can
hearing
hear
you.
you. We are
I'm
hearing
hearing
you.
you.
Okay, thank you very much for the feedback. So secondary pneumonia happens when there is a pre-existing lung condition or respiratory system abnormality, and then you now have pneumonia on top of that. So it is characterized by, the absence of pathogenic organisms in the sputum. So sometimes they can do a culture, that's the test, to check, is there any bacteria that would be cultured from this? And it might not be. It might be that while the person was eating, the person aspirated some food particles that hereby elicited a response. The person, maybe from the vomitous food that came from the stomach, contained mixed with acid, and then it entered into the airway. So these are other ways whereby, it can happen. So it could be due to trauma, that's an injury to the lungs itself. Postoperative also, maybe somebody had to be intubated. They don't have any lung conditions before now, but then they ended up having pneumonia. So I'd like us to focus on community-acquired pneumonia because it's what we commonly see. I'm not saying that hospital-acquired pneumonia is not common, but before a lot of people in the community, I work with the primary healthcare board now, and I can tell you for free that a lot of people don't want to go to a health facility. It is when things have gone bad that is when they present most times, because they feel like, oh, why should we go to the hospital? Some of them have phobia for the hospital. So these things might have been going around in the community, and then it's not that they came to the facility to acquire this infection. So community acquired pneumonia may be a primary infection in a previously healthy patient or an individual, or in association with certain lung diseases like COPD, as I said in the previous slide. Somebody that has asthma, somebody that has chronic obstructive lung disease can have pneumonia on top of that. Or it might be a primary thing. This is a new respiratory illness for the individual. The person had otherwise been healthy. And it is a lower respiratory tract infection. So we have sore throat and the likes, upper respiratory tract infection. But I told you lower down, we expect that that place should be free of, organisms infecting and eliciting all this pus formation to the functional unit. So it is a lower respiratory tract infection, and it can be typical or atypical depending on the kind of bacteria, fungi, or the virus that causes it, or whatever had caused it. And it could be as a result of, people that do research, population testing. So in Lagos Island, we found that it is Streptococcus pneumoniae that is the common thing. So they might do a throat swab for everybody and then collate the results. So we did a research on people that were coughing in Lagos Island, around the marketplace, and in some communities or houses around that area where we saw that there's a lot of cough. Streptococcus pneumoniae was what was cultured. Or it could be something else. It could be Klebsiella, which is not very common in community acquired pneumonia, but it could happen if the person is immunocompromised. So the community-acquired pneumonia is a prominent cause of mortality and morbidity due to infectious agents. I talked about the one in US as a prevalence before now. This is for India. It causes about 23% of the global pneumonia burden that they have, and about 14 to 30 cases are fatal. It could lead to serious disability or lung damage or even death in certain people. And they have also found out, just like the US, that streptococcus pneumonia is like the commonest pathogen that causes this community-acquired pneumonia. Then for some other, that's like about 29.2% based on the study I used. I think it's 2015. And then some atypical pathogens too, like 25% of those, whether gram-negative bacteria, Klebsiella pneumoniae, or Pseudomonas aeruginosa, which is not very common, in about 22%. So what are the factors that predispose you to having community-acquired pneumonia? If you're otherwise healthy, your immune system is not affected, you shouldn't come down with flu so easily, because other protective factors, the coughing, the airs from the nose, and then the mucociliary unit should help protect you, even if you're breathing in bad air. But then there are some causes that can predispose people to having pneumonia. If you are greater than 65 years of age, 60 to 65 years and above, you're at risk of having pneumonia. If you're a cigarette smoker, you're at risk. If you're an alcohol user, alcohol has like some spiral things that it happens. I mean, alcohol can make some people malnourished. Alcohol content also, it's acid. If some people have to regurgitate or to like vomit or bring out things from the stomach to the airway that enters by mistake, mixed with alcohol, it's acidic. It can also destroy the endothelium. That way, resulting in disease condition, releasing inflammatory cells, you have pneumonia, fluid filling the air sacs. Upper respiratory tract infections can lead to having pneumonia because if they're not properly treated, and then maybe a patient is semi-conscious or unconscious, and then they can't really cough out when something gets stuck, it can actually lead further down. So whatever has infected the upper airway, causing your sore throat and all manner of hoarseness, pain, can go further down and cause pneumonia. A pre-existing lung disease, as I said, is a risk factor. Recent influenza infection, which is also viral. Corticosteroid therapy, I said it, that people that have to be on steroids, maybe as a result of surgery or what have you, or for certain people that have some respiratory illnesses, we can prescribe steroid inhaler for them. It's going into the airway. It is restricted to that area, right? So that corticosteroid therapy can reduce the immune system there, hereby causing pneumonia. If there's indoor pollution, some people can have, certain things that release harmful gaseous substances, and they inhale it continuously. It is the repeated insults that would result in, eliciting a disease reaction. Antibiotic abuse. So this one is very important because certain times, certain people are prescribed antibiotics, they do not finish the antibiotics. You teach whatever organisms are in your body, a way to get smart. And then, when next you now need the antibiotic to work for this illness, it won't work. So that's why we tell people, if you have to use antibiotics, so, in the community setting or the primary health center, so many people would have gone to different pharmacists, mixed up a lot of things, even for children. And I'm like, I don't understand what's going on. I mean, this is a child. Why are we mixing so many things together? And then they now come to you when all is filled. And you're wondering, like, oh, madam, you have mixed so many antibiotics. How do we even know what is specific? And then if you send them for further tests, they might not be financially buoyant to do that. So it makes treatment very difficult. So using antibiotics when you don't need them is antibiotic abuse. Not completing your medication. The person who prescribed knows that the medication will most likely work for a number of days. We'll see it further down towards the end of the slide. The recommended number of days per age group or per causative organism to treat pneumonia. So certain people might have treated it, incomplete, and then the disease reoccurs. Then immunosuppression, cancer patients using chemotherapy destroys some cells, immune system is reduced. AIDS reduces or suppresses the immune system. Transplant patients, like I said, corticosteroid use. So there's a picture showing a table for the risk factors for community-acquired pneumonia. So certain things I didn't mention, apart from the age: diabetes mellitus, heart failure, chronic renal disease, chronic hepatic disease affecting your liver, because all these things also have a way of working in synergy to make sure we are healthy. Sickle cell anemia, there's a different disease progression from that, compromised immune system, decreased cough reflex, maybe as a result of age, or a patient is semi-conscious, maybe they fell down, hit their head, and they're not very conscious and they're lying flat. Smoking is a risk, alcohol, like I said, malnutrition, homelessness. When someone is homeless, we have them in Nigeria too. People that don't have a place to put their heads, they're exposed to cold, exposed to the fumes of the atmosphere, be it Lagos, industrial city, fumes from factories, from cars, from generator, what have you. They're not feeding well. When you're not feeding well, your immune system is weakened. A recent cold or flu. And I said toxic fumes, indoor pollutants, chemicals. So the microbiology, I just listed certain bacteria, viruses, and fungi that could cause community-acquired pneumonia. Streptococcus pneumoniae topping the list again, Haemophilus influenza, Staphylococcus aureus. If we see some of these organisms are repeating themselves, even for the broad pneumonia itself. Legionella, Pseudomonas, Enterobacter, Mycoplasma pneumoniae, for the viruses, influenza A and B virus, respiratory syncytial virus, Coxsackie virus, rhinovirus, adenovirus, coronavirus. We had COVID, some people had pneumonia as a complication of COVID, 2019, 2020, 21. Fungi in people that are immunosuppressed, histoplasmosis, cryptococcus, blastomycosis, aspergillus species can cause pneumonia. Though it's rare, but it happens because the immune system is weakened. What are the classical features, the symptoms you see in community-acquired pneumonia and pneumonia generally? Some people might have fever, high grade, low grade, depending on the severity of the disease. Most people will cough. So the cough might be dry cough, or it might be that they cough of phlegm or sputum, kelebe. Hemoptysis, some people can cough so much that, the effort of the coughing can bruise like some lining, blood lining around the throat or what have you, and then they're coughing up blood or pinkish stained sputum. Or in some cases of heart failure too, you can have those pinkish fruit sputum. Shortness of breath, as a result of the decreased gaseous exchange due to fluid making that component a bit dense. So gas is not going in very well. Some people could be breathless. Pleuritic chest pain, they can describe it as a sharp or stabbing pain. Non-specific symptoms in elderly, some people might say, oh, they have, joint pain. Some people might be confused. They might not be aware whether or not they had dementia before now. And then they might not even have fever. They might just be generally weak, fatigue, malaise. Some people might have headaches. So what do they see when they present to the hospital? A lot of them look very ill. They might present in shock. Like I said, some of these things can enter into the bloodstream such that you have sepsis. That is now like a general infection going along the blood level, along the blood vessels to other organs, other parts. Some of them might have given you an history. When you ask them, oh, when did this start? What happened? They'll tell you, oh, they had flu, they had runny nose, their eyes were watery a few days before they developed fever, cough, and sputum. Fever, tachypnea, meaning fast breathing, or tachycardia, their pulse rate when you check with a pulse oximeter is high, greater than 120 beats per minute for an adult. Then when you listen to their chest with the stethoscope, on auscultation, you hear certain lung sounds like crackles that can suggest that, oh, there's fluid in this place, oh, the breathing exchange is not proper. There's some people have low blood pressure and then confusion, like I said, they are not mentally oriented. There's just a picture showing the endothelial or epithelial cells, toxins going in, neutrophils and macrophages being released on slide slide 23. Macrophages being released and what have you, and then um how they go in, immune invasion, like we've explained before. So what are the tests you do? Investigations for these people that present in the hospital. You do a full blood count because you want to see if the white blood cells are elevated. When the white blood cells are high, it tells you that the body has been trying to fight something. When you do a pulse oximetry, you put a small device on the thumb of the patient or the finger. It tells you the level of oxygen saturation. Are they getting enough oxygen in their cells? So in certain people, it could be lower than 90. The threshold is 94%, at least 94, 95. It shows that you're breathing fine. You don't require oxygen. Less than 90 is most common in people that have pneumonia.
Hello,
Random
doctor.
blood.
Hello,
Yes, ma'am.
doctor. Please, can you
Yes.
hold on for just a second, please?
Okay.
Okay, please unmute yourself.
Okay. So I was saying that certain investigations that we can do in the hospital setting. The pulse oximetry shows the level of oxygen saturation, if a person is getting enough oxygen or not. You can do a random blood sugar, it's part of the routine test to rule out other infections. Other conditions rather that can present like that. Then we have serum electrolyte. There's a scoring system I'll go to shortly that would show certain imbalance of certain ions. Then you can do a blood culture, though it takes longer to get the results. And then a chest x-ray, like I said, can tell you if there's a lobar pneumonia, if there's consolidation, if it is an interstitial pneumonia. There are different things we see on x-ray. Arterial blood glasses in well-established facilities whereby it is available, but if not, as you go further down, they are not very common. Invasive technique like bronchoscopy, so they can use a device that has a camera to check and see the sputum at the lower levels. So there's a way we score how severe the person presents to determine if the person will be admitted or not, or if the person will go home with oral antibiotics. So the scoring system, you can do a chest x-ray, which will show that one or more lobes are involved. That is a prerequisite for admission. With the white blood cell count elevated and the full blood count, like I said, will show that, there's a disease condition, or if it's very low, shows that the body has certain things, and then the white cell was reduced. I'm having a feedback here, but let me just continue. So a positive blood culture culturing bacteria or fungi or what have you would also give an idea. You can do a urea assay, though it's not very common, and then it can show that the urea is greater than 7 millimoles per liter. Then when you do the serum electrolytes, you can see hyponatremia in certain cases whereby sodium is reduced. So there's a scoring system, like I said, it's called CURB 65, CURB 65. I said earlier that a risk factor or something that can predispose us to pneumonia is being greater than 65 years of age. So each component has a scoring system, 1 point for each, right? So CURB 65, CURB or CORB tells you, when you see these things, these are the things that you use to determine if person can go home and use oral antibiotics and come back for review, or the person needs to be admitted immediately. If a patient is confused, it shows that the disease progression is severe. That's 1 point. If the urea is greater than 7 millimoles per liter, but in our environment is not very common, you can easily get a pulse oximeter, which shows the level of oxygen saturation. And if it is less than 90%, that is 1 point. Respiratory rate greater than 30 cycles per minute. I said tachypnea, they breathe faster. The maximum level you expect for a normal adult is 20 cycles per minute. But when you have 30 or upward, it shows that there's so much effort to try to breathe because something is going on in the breathing unit. Blood pressure less than 90 systolic and 60 diastolic shows that there might be some level of shock. The person is hypotensive. So when you have a score that is 2 or greater than 2, it gives you, an idea that this person needs to be admitted. And then 3 to 5, if possible, ICU admission because it's critical. But if you have a score point of 0 to 1, you can use antibiotics orally. That's what that picture is showing, the CAP slide on slide number 28, because I'm trying to put everything together. They are similar. On the green side, you don't need to really, really panic. It's a COP score of 0 to 1. They are managed as outpatient or inpatient for social reasons. Some people might feel very unsafe and they just insist you admit them. And then the antibiotics might be a monotherapy. You don't need to combine with certain other things, especially if they don't have other disease conditions they're using medications for. A COP score of 2 is a moderate risk. So it tells you the risk assessment. The person will be managed as an inpatient. They don't need ICU. You do all those microbiology tests to get the specific organism causing it and how to treat appropriately. And you most likely combine antibiotics for them. So for the high risk, 3 to 4, 5, like I said, might require ICU monitoring, IV fluid, IV medications, and then several combinations of medications. So what are the general principles of managing pneumonia? I put as general principles because we can use it to manage viral, use it to manage the fungal, but I will just try to elicit several explanations. So for, checking simple things, the blood pressure, the oxygen level, you correct adequately. So if the person has a oxygen level that is less than 94%, you give oxygen to correct to at least above 94%. That shows that the person can breathe fine on their own. If they are dehydrated, malnourished, you might need to give fluids, IV fluids. If they are in pain, I told you they can describe the pain as a sharp pain, stabbing. You give analgesia. In the case of malnutrition, nutritional support and advice. In case of joint pain and what have you with the elderly, physiotherapy, spirometry, and some other therapy. And of course, antibiotic use, because something is causing it and we need to fix it. So I just gave some examples of antibiotics basically. That okay, for the low risk, that's the COP score of 0 to 1, you can use amoxicillin 3 times daily, 500 milligram, in combination with clarithromycin 500 milligrams twice daily, or doxycycline, once daily, as the case might be. Or in some cases they give penicillin, but if there's penicillin allergy, that's when you use clarithromycin or doxycycline. In moderate, your amoxicillin, commonly common here in Nigeria and easier accessible, 1 gram 3 times daily, either with benzoyl penicillin or clarithromycin. If there is a penicillin reaction, you replace penicillin with doxycycline or levofloxacin, as the case might be. For people that are admitted outside the hospital, they can take orally. For people admitted inside the hospital, you want to limit the number of IV stuffs if they are not comfortable with it, but you give the most important that will work faster too. So you can combine oral and IV or give all IV depending on it. Severity, I gave like examples of different classes of antibiotics, coamoxiclav, ceftriaxone, cefuroxime, the generations of cephalosporin with a combination of clarithromycin, be it a macrolide or, a fluoroquinolone like ciprofloxacin, levofloxacin, what have you, which can be given. And then, there's a Legionella disease that can be common also. So, okay, I'll wait for the question time. It might come up as a question. So, if Legionella is suspected, you use levofloxacin IV twice daily. So the duration of antibiotics, like I said, for people that are outpatients, 5 days to 1 week, but in some cases you can give up to 10 days to 14 days, that's 2 weeks. And then for people that have been exposed to chronic steroid use, greater than 2 weeks, span up to 3 weeks. For Staphylococcus aureus, Legionella, which are not very common, but when they're cultured, you want to, elongate the antibiotic therapy to like 14 to 21 days. So criteria for discharge of patients. How do you know when to discharge a patient? They came up with fever, breathlessness, increased heart rate, tachycardia, increased respiratory rate, tachypnea, low oxygen saturation. So what makes you, discharge people is that you have seen that, they have improved in their condition, they appear clinically stable, and they don't have more than one of these signs. So the temperature might still persist greater than 37.5 degrees. The heart rate might still be high, but not both. The respiratory rate might be greater than 24 into 30 cycles per minute, but it doesn't have to coincide with fever and temperature and increased heart rate. And then oxygen saturation has to be improved definitely, because you don't want them carrying an oxygen cylinder home. Then you have to be sure that they can maintain oral intake. How do you discharge people? They can eat on their own. They don't have risk of aspiration, especially if aspiration was one of the causes of this illness. Then altered mental status. There are complications of pneumonia. Pus can fill up the pleural space aside, the lung lobes, empyema, lobar collapse, DVT in cases whereby the patient has been bedridden for a long time. That's the next slide. Whereby they've been bedridden for a long time, they are not moving, they don't have this protective TED stockings to prevent clotting or embolism or venous thrombosis. So DVT can occur in the legs because they are not moving about to move their blood around, and then it can even enter into the lungs, causing a pulmonary embolism, which is a life-threatening condition. Pneumothorax, suppurative pneumonia, there can be abscess formation by poorly treating it, hypoxemia, oxygen is not getting enough to the blood, sepsis, as I described earlier, that if there's a breach in that endothelium covering, it can enter and then spread through the blood vessels to other organs, hereby causing pericarditis, When I said itis, we have inflammation around the heart, hepatitis affecting the liver, myocarditis affecting the heart muscles, meningitis. It can even go to the brain because, I mean, this chest cavity is connected to blood vessels that go up and down also. So meningitis can occur in certain people. They can have acute respiratory distress syndrome. They can have renal failure, multi-organ failure that can result in death, in certain areas. So is this thing preventable? Yes. And when a disease is preventable, I would rather a person goes to prevention, like I said, preventive medicine rather than curative, and health education too. So what are the risk factors? That's what we'll bring back to know how we can prevent pneumonia. If you're smoking, if you're taking alcohol excessively, it will be advised to stop because these things are harmful. Smoking changes the structure of, that mucociliary structure such that it destroys it. It doesn't work properly. Then the fumes also that go in are also toxins. Alongside alcohol, like I described earlier, vaccination, there are vaccines given to children. So take immunization for your children. There's a pneumococcal conjugate vaccine. There's vaccines for pertussis, for Haemophilus influenza given to them from, ages 0 up until 14 weeks of life. And then adults greater than 50 years can have booster doses of these vaccines to protect against influenza, a common cause, pertussis, measles, pneumonia, pneumococcal pathogens that can cause these things. Then you tackle malnutrition. In the case of malnutrition, you address indoor air pollution. You talk about cross ventilation and how people can reduce, toxins coming into their living space. Hand washing and hygiene, very important, especially for community acquired. So you cannot necessarily get pneumonia from another person, but if you are susceptible, if your immune system is weakened, if you now get droplets from cough or sneezing of somebody else, it can predispose you to pneumonia, if that makes sense. So you can't necessarily get it like COVID, but if you are susceptible, if your immune system is down, you can get those bacteria, droplets going into your lungs and then eliciting a response. So hand washing, hygiene, good cough and sneezing etiquette. From the times of COVID, we know it's into our elbow, or you get a disposable, handkerchief or what have you, such that you dispose after use. Then for Legionella, you inform, the health authority, appropriate health authority, the DSNO, the disease surveillance notification officer, if it's in a community, must be notified because these are rare and they can cause more damage. What's the prognosis? Most patients can feel better within 2 weeks. However, for some people that are elderly that need supportive treatment, or people that have had like long illnesses before now, respiratory illnesses that are predisposing, it might affect them and they might need further treatment. Then for fever, the fever might not go 100%. That's why I said we can discharge them if that's the only criteria left. And then for some people, they might do x-ray, to check again if the lobe that is affected is improved or what have you. And then mortality rates might be not severe, in people that, like if the disease is not severe, it's low. But if they have this hospital acquired, you get more germs from the hospital, and then there's weakened immune system, it could be higher, that can even lead to death rates from as low as 5 to 10% to as high as 50%. So certain things can appear like pneumonia. I said asthma, atelectasis, that's like lung collapse, bronchiolitis, bronchitis. It's not necessarily pus-filled, it's just inflammation of this upper airway. Chronic obstructive lung disease, which can be, existing. Foreign body aspiration, when a large particle enters and you're not able to get it out, it can present with breathlessness, also hoarseness of voice, pain, discomfort, and what have you, you know. And then lung abscess can also be a differential. I wrote here COVID-19 can be a differential, although we've not really had those these days. Cancer, a neoplasm of the lung, can also be a differential. Tuberculosis can be a differential. Permit me for not putting that. Heart failure too. Aspiration, what have you. So thank you very much for listening to this elongated, broad presentation. I'll take questions now. Thank you.
Thank you so very much, Dr. Demilade.
Thank you, ma'am.
Very robust presentation. Much appreciated. Okay. Our participants, thank you for still being on the call. And we are now on the question and answer session. So just a reminder, if you have any question or any contribution, kindly raise your hand or and I'll call on you, or you can put your questions in the chat box. Okay, Chief Mrs. Mutupe Koka.
Good morning, all.
Good morning, ma'am.
Good
Good
morning,
morning,
doctor.
ma'am.
Please, I
Good
just
morning,
want
ma'am.
a clarification. During the
Yes, ma'am.
course of your lecture, you
Yes,
did
ma'am.
say they put patients on coma to stabilize their organ, but initially, I believe people fall into coma. I don't know that people can be put into coma. I want a
Oh,
clarification on that, please.
that is
Thank you.
Okay. So do I take all the questions as they go or do I answer as we go?
No, answer as they go.
Okay. So yes, people
Please.
can fall into coma for a several number of reasons, be it as a result of uncontrolled diabetes that can lead to coma, a head injury, whatever mechanism can lead to coma in certain illnesses. Even severe malaria for some people can make them unconscious or fall into coma, as simple as malaria is. However, I said that for some people that might require ICU admission, if they have to put something in your throat and you're aware, it's very difficult because there are certain inbuilt um, mechanisms that will not make it go down well. So for a patient that needs to be placed on ventilator, if they are awake and aware, they might fight the intubation and what have you. So there can be medically induced coma. In such a case, such that, for the people abroad, they might do that a lot of times. You are seeing multi-organ failure, you feel like there's nothing you can do at the point to rescue that situation. So you want to put them in a medically induced coma. You medicate them so that they sleep, attach them to a ventilator for the chest to help with breathing. So these machines take over your function, basically, to help you recover. So some people can be put in medical coma, but it's in extreme cases, and the consultants and higher medical elders take that decision alongside families' consent. I hope that
Thank
answers your
you.
question, ma'am.
Yes, thank you very much.
Thank you, ma'am. I think that some people have put something on the chat
Okay.
box. Can I attend
Yes.
to
What can be
that?
done to help a known smoker to leave smoking, to stop smoking?
To stop smoking. Okay.
Yes.
Well, it's a lifestyle choice and it can be attached to beliefs. Some people might believe that, oh, the weather is cold, so I needed to warm myself up. Several beliefs. We have different belief systems. If it's okay for certain people to condition their minds and, forget about smoking naturally, it can happen. But it's usually harder for people that have done it for a longer period of time. So in those cases, they might need, behavioral therapy, needing to see a psychologist and other people that can help rehabilitate them to work with them. So you can have a scoring system. Did you smoke today? Have you reduced your packets? It's a gradual thing. It doesn't happen abruptly because there are withdrawal symptoms, which can be very, very serious, that certain people will think they are going to die and they'll rather go back to the smoke, even if it's going to damage their lungs. So, they can work with psychologists, work with certain medical professionals trained in the field to help them. Oh, so how do you do it? You've been smoking 10 packets. Can you reduce it and cope from reducing to stopping, from symptoms and ultimately rehabilitate them? So that's how a non-smoker can stop smoking. There's willpower, yes, but you would also require help and social support too from your family and friends. I hope that answers the question for the person who asked.
Okay, thank you. There's another
Thank
one. I have been coughing for about 3 weeks now. I have taken 2 bottles of cough syrup. Could this be pneumonia?
Okay, so for the person that asked, if you see in the presentation, I said, how do we determine what pneumonia is? If you've been coughing for more than 2 weeks, I mean, they advertise it on radio and then posters and what have you. Cough longer than 2 weeks, please see a doctor. It could be pulmonary tuberculosis, which is a differential, and it could be pneumonia, and it could just be, a chronic um respiratory infection, such have you. But you don't know until you present in a health facility and do certain investigations, the full blood count, the chest x-ray when required, and some other blood tests and pulse oximetry and supportive investigations. So you cannot determine. And then, the idea of people saying, oh, you use cough syrup. I didn't go in depth into the viral part. The viral part basically does not respond to certain medications or cough syrup as it may be. Because when we have a viral infection, say a common flu, you give it time to get better. You give your body time to, overcome these things. Because your body can always handle a viral infection. It's when it is really severe, you might now need maybe some antiviral medications. But ultimately, your treatment for viral pneumonia is usually supportive. So what are the things you see? You see fever, you give something for the fever. You see pain, you give something for pain. Fluids are reduced. Maybe the person is dehydrated. You tell them to take in fluids if they can tolerate orally, or you give IV. Because when you're more hydrated, you can break up the mucus plug. So using cough syrup is just one thing, an expectorating thing that helps you cough up, the phlegm or the sputum that is blocking your airway. It doesn't solve your underlying problem. So when you get to a hospital, you know what is causing your symptoms and get adequate treatment. So cough syrup is not like a treatment in this case, whether it's pneumonia or any other thing. Okay.
Okay, another one. We often hear, don't expose yourself to cold environment so that you don't get pneumonia. So the person is asking, is cold weather a major causative factor or is it microbes? Okay, is cold weather a major factor or is it microbes?
Okay, thank you for the question. So I was going to mention that when I mentioned Legionella, but I was like, oh, let me wait for the question to come in. So yes, there is the popular saying that, oh, when you expose yourself to cold, direct AC, it can cause pneumonia. Yes, in rare cases, droplets of the AC can contain Legionella. That's why I said in cases of Legionella disease, if it has been identified, you need to, notify the disease notification officer because it can be spread. And I said that for the community acquired, when it is spread, certain people might have a predisposition to pneumonia. And then this organism gets into your airway by breathing in the common air where someone coughed around you or sneezed directly on your face, and then you get it. So cold can be a precipitant. Cold can be a cause, like in the winter, like I said in the statistics I presented earlier, or cold weather. It can be a prerequisite for viral infections, for flu. And I said in the earlier part of the presentation that you might have, flu-like symptoms or previous, in the presentation, you might have previous flu that the person just treated, and then the person comes down with pneumonia. Maybe it's poorly treated. So cold can be a precipitant. Then for people that are susceptible, Legionella disease can occur as a result of chronic AC use that would now, get the organism into your airway and also elicit pneumonia, because Legionella can cause pneumonia, though in rare cases. But if you're otherwise healthy, I mean, things you can do is reduce, the source of cold, get a heater, warm fluids, to get off your flu-like symptoms. And supportive therapy, you can use supplementations. If you don't have ulcer, vitamin C, it boosts your immune system, acts as an antioxidant, that can help you. So organisms can cause, cold can be a precipitating factor. AC can introduce the organisms in form of droplets. But ultimately, the causes are either you aspirate something, toxic chemicals, commonly bacteria, virus, or fungi. I hope that answers your question, please.
Yes, I believe so. Dr.
Okay.
Oduwole, good morning, ma'am. Do you have a question?
She said she
Good
has an
morning.
input on the vaccine
I have
status.
an input. Thank you very
Okay,
much,
thank you.
Dr. Demilade.
Thank you. Thank you.
Okay, that was a good one. But I have an input in that Nigeria is yet to have a national policy on vaccine for the elderly, the pneumonia vaccine for the elderly. I wonder, I'm happy that you are from the Primary Healthcare Board. So I just want to know how far you have gone with this, because I actually took it up with somebody in Abuja, one of the policymakers. And what he told me was that they are more for the younger children, for the children. And I remember we lost one of our former presidents due to global pneumonia. So I don't know how far you have gone. I went around to look for, I could only get PCV 13 in Nigeria, whereas in other climes, they are getting up to 20 now, PCV 20, and 20 can cover you for life. Then in some places, if you get the PCV 15, then later they give you the PCV 20. And then the diabetics and so another people with lowered immunity can get it earlier, between 19 and 64. They don't have to wait till 65. But I just want to know what the government is saying about pneumonia vaccine for the elderly, to which we belong. Thank you.
Okay, ma. So, like you rightly said, I mean, there's no policy like the national immunization schedule for children, whereby you advertise and say, okay, come and get a booster dose of, the pneumonia vaccine. I'm not aware of that since I joined the primary healthcare board. However, while I was in Reddington, I'm aware that certain adults come specifically to have that booster dose, but then it's at a cost. So people can have that provision. However, it ought to be a global thing, like a general immunization thing, especially for the elderly, because it will go a long way to help them. But I remember when we had like the diphtheria outbreak months ago, they advertised that people should come to the health center to have a DPT booster dose. So I think many times we wait till something comes up before we get the booster dose rather than preventing, which is wrong. But I really hope that in the coming months and years that there's an outlined immunization schedule even for elderly and then people at risk with these comorbidities that you mentioned. But for now, I don't know of any except they are having it out of pocket at certain places and they
So
buy the whole thing. You don't have to wait
that's the
for,
message we are sending you. That's the message we
okay.
are sending you back to them. Thank you.
Okay, ma. All right, ma. All right, ma.
All right, thank you. Madam Odugbeson, good morning. Please, you have a question?
Oh, there's a question in the chat box. Could cold drink intake cause pneumonia?
Oh, okay, yeah.
It still goes down to saying that cold can be a precipitating factor. But then in the case of cold drinks, not directly, except the person aspirates the drink, which is like what do you call it now? A foreign object or a foreign substance that enters into the lower airway and can elicit all manner of inflammatory reaction. So not directly, however, some people might have the myth of if you drink cold things too much, you are used to it. You are prone to it. We have established that bacteria, fungi, and what have you can cause these things alongside chemicals and toxins that are inhaled, but cold can be a precipitating factor. So in this case of drinks versus AC inhaling droplets that predispose you, it could be in the form of aspiration that it can elicit those reactions. I think there's another question here.
Yeah. If one always has a running nose, does it mean the person has pneumonia?
Okay, so running nose is more like an upper respiratory symptom that could be with the common flu, like I said earlier. So sometimes these things might coexist, but it's not one sign that will say this is pneumonia. A pneumonia could exist alongside, the running nose, telling you that there's a viral thing going on, and then there's like a bacterial superimposition or superinfection that causes pneumonia. So one cannot really say until you go to the health facility, like I said earlier. So several investigations of which ordinarily you won't do a chest x-ray for a running nose, but you can elicit other things like they listen to the chest. What are the sounds, the lung sounds we're hearing? Is it suggestive of pneumonia? Are you having difficulty breathing? Is there reduced chest expansion on a side? Those are things that the doctor sees to most likely suggest pneumonia. And then percussion notes. There's something we do about percussion, trying to check the lung sounds and listening. So does fluid travel faster? Is it louder in one side? So when you see that these signs point to pneumonia, then you do specific investigations for pneumonia, be it a chest x-ray, culture, what have you. But ordinarily running nose on its own, we can't say until we test for it. Yes, so that's my
All
answer
right.
to that question.
Another question. Is asthma curable?
Okay, I missed that. I've seen it now. Oh, so asthma is an underlying respiratory illness that has allergies at play. Permit me to say that. So certain things elicit this response, such that be it dust, smoke, predisposition to allergic reactions, cause the bronchioles. If you remember the picture of the lungs, if you can put it there to that slide, from your nose, from your nostrils, you breathe in air all the way to the windpipe. There's narrowing of these bronchioles and the windpipe itself, narrowing and then filling up of these chambers that branch out towards the alveoli with mucus, such that it covers the lumen. It covers, like, okay, the pipe should be 10 millimeter in diameter, is reduced to 4. It's the same thing with your plumbing system. If you have like a narrower pipe delivering water, it won't deliver at that pressure that you need. So the same way for asthma, it's just a way to simplify it. What happens? So it's a chronic illness because it can have its seasons, it can go on and on even outside its season, of which there's structural change of the otherwise breathing units further up, even branching into the alveolar, such that that narrowing and mucous coating of the windpipe itself gives you reduced air entry that would not allow sufficient air to get to the smaller air-filled sacs at the lower zone, if that makes sense. So asthma, it's a chronic condition. So I wouldn't say necessarily cured, like, oh, you have malaria and then malaria goes, but you can manage it. It's what you can manage, like diabetes, is what you can manage, like hypertension. Though these things can be improved, such that some people say they have been cured. But if you look at the structural pattern, those structural changes might still be there. Not as severe as it used to, but it would give you an idea that this is it. This occurred. Narrowing, mucus filling, thickening of the muscular or the mucous wall, the wall of the bronchioles, which is not supposed to be. It should thin out as it goes. So asthma can be managed such that you feel like you're cured, but certain chronic illnesses are not necessarily cured, in my opinion.
Okay.
Do we have other?
Oh, have you seen another question? I don't think
Asking if there
so.
are other questions, basically.
Okay, no. Most of them are just appreciating, yes. Okay. Does anyone have any other questions? I don't think so. Okay, thank you,
Okay.
doctor. I would call on someone to please appreciate our facilitator. Does anyone want to, or should I just do a random selection? Okay. Mr. Abdul Malik Abiodun. Okay, Mr. Adenuga, good morning.
Good morning, please.
Good morning, sir.
Good morning. Thank
Yes,
you.
sir.
Thank you for
Yes.
the session.
Thank you, sir.
Okay. So, okay, you want me to do the presentation? Is it,
Oh,
Mrs.
I thought you
Ola?
had a question or something. You unmuted, so I
No,
was. Oh, okay.
no,
Yes,
no.
please go ahead. Oh, it's gone off again.
Okay. Once again, good morning, and we thank God for this session. It's been wonderful. It's been very educative, very enlightening. and we have all been blessed, and our knowledge has been enlarged. So we, on behalf of the department, on behalf of the retirees and everyone on this call, Dr. Demilade, we are saying a very big thank you to you. And we pray that God is going to bless you. God is going to make you a channel of blessing and joy to humanity as you are working very hard to save lives and to make life more comfortable. God is going to bless you and all that concern you in Jesus' name. Once again, we say thank you. And we say thank you to our HOS. We thank you to our permanent secretary, to our director, PSD, we say thank you. And to Mrs. Roland, our anchor, we say God bless you too. Have a blessed week. Okay.
Thank you so much, everyone. Thank you.
Dr. Agbengalao, good morning. Do you have
morning.
something to say? Good morning, sir.
Thank you very much. I wanted to just ask a question then. And the question is that can we regard pneumonia as a partially lower level to asthmatics or something like that? Is that's just what I wanted to ask that time. And secondly, I want to add my voice to the call that the government, you should please look at giving more provisions to more attention to the need of the elderly medically. Thank you very much.
Thank you, sir. So if I get your question correctly, you're asking if in classification, pneumonia is lower than asthma.
Yes.
Do you think I'm trying to ask, is it in like severity of the disease or how do we classify?
Severity.
Well, I said in the presentation that pneumonia can be low risk, high risk, mild, moderate, severe, and then the recuperation time, the treatment differs according to how you see if it is severe using the COP score alongside other clinical symptoms. Asthma also can be, mild. It can have acute presentation. It can present as an emergency. So I wouldn't say that one disease is above the other. However, I would also say that in the places of classifying it, so asthma is more non-communicable, like you can't spread it to somebody else. You have to have like predisposing factors that help you, calm down with this. Versus pneumonia, in which even though it can be directly spread in certain cases, except weakened immune system being in the hospital or weakened immune system being in the community, it can still travel through droplets. But asthma is like a structural problem precipitated by allergens. So I wouldn't say one is above the other. I would say they can all span from mild to severe or life-threatening, as the case may be.
God bless you.
Thank you, sir, for the question.
All right. Thank you. Thank you, doctor. Your presence has been much appreciated. All right.
Thank you for
Okay,
having me.
I can see something here. Please always let us call another. Oh, okay. Yes, thank you, ma, for that. Please, ma, or everybody on the call, you can please send messages to other retirees that you know so that they can join the webinar so that we'll have more participants on the call. Thank you for that, ma. Thank you very, very much. Yes. And this is just to remind us that we can also go to YouTube, to our channel on YouTube, to watch this particular session and past ones that we've had, so that you can know all about all the other sessions that we've had, other topics that we've talked about. Okay, I think we have one more. Oh, okay. All right. So thank you everyone once again for joining today. Let's all unmute ourselves and see ourselves and say hello to one another as we usually do. Thank you very much, Doctor.
Thank you
Thank you.
very much, Doctor. We love
Thank you very
Thank
much.
you.
Thank you.
Very happy about
Good
it.
morning, everyone. Good morning. Oh, it's afternoon now. 12 o'clock.
Good morning.
afternoon.
Thank
Just
you very
any
much,
retiree.
everyone.
Morning, everybody.
Good
Good
afternoon.
Appreciate what the PSO is doing for us.
everyone.
Till another time.
I'm happy to be here.
God bless us all.
God of
Protect
Thank
us.
you.
Madam Victoria. Nice.
Good afternoon,
This is
everybody. Good
Good
afternoon.
afternoon. Good afternoon, everyone.
Appreciating
Good
your
afternoon. Thanks so much.
Good afternoon,
thanks for
all.
coming to
Really appreciate
the
Good afternoon,
Thank
Simon.
you.
God bless us all.
Good
Amen.
afternoon.
God bless you, Dr. Dumade.
Èmi náà kí yín o, mo kí everybody o, Mrs. Oníkòyí kí
Ṣọlá,
everybody
hello.
o, a dúpẹ́ o.
Akinyo, ẹ ṣé o.
Thank you.
Thank you, Doctor. God bless you. All grace.
Bye.
Bye.
Appreciate you all. Thank you all. Mrs. Roland, thank you.
Yeah, most welcome.
Thank you.
Thank you for joining.
We really
All right.
appreciate you.
I appreciate you all.
Hello, thank you. Bye-bye. Bye-bye.
Thank you.
Thank you.
Bye.
Bye.
All right.
Have a nice time.
Thank you.
Bye. Thank you.
Bye. Bye.
Let us please.
Yes, we are done. So next month, November, by God's grace, we will have another interesting topic.
Okay.
So look forward to seeing everyone next month, November, by God's grace.
All right.
All right.
All right.
Okay. Thank you.
Okay.
All
Have
right.
a wonderful day.
you. Same here to you.
Bye, everyone.
And we know your handle on Facebook. I mean, YouTube.
On YouTube.
On YouTube. Okay.
Your handle on YouTube.
PS Retirees Cooperatives.
Come up again.
Please
PS
come up.
Retirees Cooperatives. MS.
Okay. Okay. Thank you very much.
Thank you.
Mm-hmm.
Bye. We all love you.
Remain blessed.
God bless you, sir.
Public Service Retirees Cooperative.
Yes.
So you just go on it and you'll see all our sessions. Thank you.
Thank you. Thank you very much.
You're welcome.
So much, man. God bless you.
Amen. And you too, ma'am. Bye.
Okay. Bye.
Bye.
Bye. Mrs. Finney from Ifakojaye, we really appreciate you all, sirs and mas.
Oh, thank you, ma'am. Well done, ma'am.
Mama boys, we appreciate you, ma.
Oh, she's not on the call right now, ma.
Okay.
Yes,
Thank you.
You're welcome, ma'am.